old
This
are you?
conference will now be
I'm
recorded.
72 years old.
Okay.
And,
And when were you first diagnosed?
well, my daughter lives in San Francisco. We spent 2 summer months, July and August, with her. And every June, I get my blood tested. And last June, my PSA went up from 4.8 to 5.8. And my endocrinologist suggested that I see an oncologist. And so I met an oncologist, and he did a physical examination and said that, look, there is enlarged prostate and looks benign, but I would like you to undergo, free F.S.A.R free ratio PSA and an MRI after I come back in September. So in October, I first got PSA and free PSA done, and it had gone up to 5.97, and free PSA was 9%. So that was a red flag. And then we had an MRI, which was 3T.
I'm sorry, Pradeep. What was the number on the free PSA?
9%.
That was the ratio was 9%?
Yeah, ratio, yeah. And PSA was 9.74, no, 5.97.
5.97. Okay. Got it. Okay.
So then the doctor suggested a 3T MP MRI for prostate. And the findings were that there was a ill-defined T2 hypo area in right posterior peripheral zone, mid and base, measuring about 20 by 13 millimeters. And PI-RADS was 5 and PSA density was 0.24. So doctor suggested that, there is a suspicious lesion, one lesion, and that I should undergo biopsy. So
I'm sorry, just the PI-RAD you said was what? What did they call the PI-RAD?
Five.
PI-RAD 5. And what was the size of your prostate too?
Prostate size was 4.9 by 3.8 by 2.5 centimeters. That's 46.5 cc, and volume was 24 cc.
Okay, wait. Okay, so wait, the size of the lesion. I'm sorry, the prostate.
The report says the prostate size is 4.9 centimeters by 3.8 centimeters by 2.5 centimeters.
Okay, and that comes out to
for a total of 46.5.
46. Yeah.
46.5 cc.
Got it. Okay.
Okay.
So not that
Okay.
big.
Okay. Yeah. And so a biopsy was done. 26 core transrectal TRUS guided MRI guided biopsy, and 26 core biopsy was done. 14 on the left lobe and 12 on the right. The left lobe was all benign, and the right lobe was 3 point. Right lobe was all 6, 3 plus 3.
But all 12 cores were 6.
Yeah, that was 12 core. 12 core, all 6, all 3 plus 3. And overall, it was 30%. Base was 50%. Overall size was 30%, it says. And then the right base, however, was 50%. And there was no other. It didn't show any other patterns. No what do you call perineal invasion and things like that. So then the doctor suggested, on the biopsy, the right apex was 10%, mid was 15%, and base was 50%. So, and then the next step, he said, okay, you need to do a PET scan, and a PET scan was done. It seemed to be all clear. It said it was localized. Localized lesion in prostate only, no nodal or distant metastasis. So everything seemed okay there. So, and if you want, there's something called SUV max was 9 to 10, and no nodal involvement. So then doctor discussed with me the options, active surveillance, surgery, and radiation. He explained all the pros and cons, and he recommended active surveillance, and which was my option two, choice two. But he said that I need to undergo a genome test. The Decipher test is not done in India. He said undergo genome test.
Right.
While and in the meantime, my wife's cousin is an oncologist. He said he should get a second opinion on biopsy too, and that's where things change a little bit. And while I had given my slides for genome test, I got a second biopsy done. Review done. In the review, the left lobe was all benign, but in the right lobe, there was a difference, and it was right apex was 3+3, base was 3+3, but in the mid region it said 3+4, and 3+4 was about 10 and 20%, 10 to 20%. There was one 10% and one 20%. There were two tissues taken. One was 10 and one was 20. So it was graded as grade group 2. So, and then it also said that caribriform pattern was found, and there was some there was some invasion. What invasion is that?
Perineal invasion.
Yeah, transperineal invasion. So, and then in the meantime, the genome test, BRCA1, BRCA2, and some 24 genes tests came, and they were all clear. And I met the doctor again, showed him the second biopsy, and he kind of, he was not, in the first place, he was not very keen that I should go and do the second biopsy, but he brushed it off, saying that it doesn't make any difference to, the treatment, and that's fine, there is a difference, and he kind of ignored it. And he didn't seem to be concerned about it. And he said, oh, well, the genome test is all fine. So continue with that every 3 months PSA, and maybe in October, 1 year, after 1 year, you should do a PET scan. So, and then that was fine. But in the meantime, this difference was bothering me. I got a third opinion got done. The third opinion was also somewhere in between. So it said, left lobe is all benign, right lobe, right apex is 8%, mid is 3+4. It also said 3+4, and right base is 50%. So that was all consistent. But it also said that there is no caribriform, and there is no invasion and things like that. It was clear. So it was in between the two assessments. And then last month I got the first PSA done. Before I met the doctor again, and my PSA had come down from 5.97 to 5.5, and the ratio had gone up from 9 to 9.73. Well, the doctor said it's all fine, and you continue our active surveillance. But he also added that maybe in 3 years' time I may have to undergo some treatment. And I asked him, when will that be? He said, I will tell you. I don't know if there is any. I asked him if there is any tipping point. He said, I will tell you, but for now, you will be on active surveillance.
All right, Pradeep, a couple questions. Who were the doctors you were getting? The first doctor, was he in San Francisco? Were these American doctors? Or
No,
these
it's all Indian doctor. He's a well-known doctor. He's a well-known doctor. All Indian.
I don't know. Do we know any doctors in India, or?
No, I don't think so.
It's, if you go to San Francisco, UCSF is terrific for prostate cancer.
Yeah.
There are a couple things I would be concerned about. One is, and I don't know if you can send the slides to New York, but they're two pathologists that basically all they do is prostate cancer slides. Epstein and Zhao. I would be concerned with your SUV max, your uptake, because that's moderate uptake of PSMA. The doctor wasn't concerned with that 9 to 10. You said it was 9 to 10 SUV max.
Yeah, I believe so. I think so. Yeah.
That's moderate to high uptake. So you could also probably get a video consultation with one of the UCSF doctors if you wanted, or if you would go there to see your kids. It's Cooperberg is good, and then Peter Carroll too, are both very well respected.
Cooper, can I get their contact details?
Yeah, let's let me do we have theirs? If not, I can find
I don't
it.
have theirs handy.
I can let me get it in the meantime. I'll post it to the chat. I will I'll post it to the chat. The other oh, did you say you had a Decipher score or genomic?
No, I didn't. I got genome test, then they were all negative. That's all clear.
That's the genetic tests they did for like
the BRCA1, BRCA2, yeah, those tests. And Decipher is not done in India.
Yeah, I'm wondering if there's a way you could get a sample sent to Decipher or Polaris, one of those, because that would certainly be very helpful to you.
Okay.
Yeah, Ray, I wanted to, I don't know about anybody else, but I don't know what SUV max is. I don't know if I've ever heard that before. What are we talking about?
He had a PSMA PET scan, and basically the PSMA PET scan test for an uptake of PSMA, and they give you a score. It can somewhat correlate to a Gleason score. And a 9 to 10 is that's fairly high. I'm not sure. I'm not sure that's if American doctors given would consider that him a candidate for active surveillance with that, especially 3+4. It's a fairly high uptake of that. A lot of times, a lot of people on active surveillance, if they have a PSMA PET scan, it won't even show up. It's like a 3+3. Gleason 6 won't even show up. But a 9 to 10 is fairly, I believe it's fairly high uptake.
One more, excuse me, I have one more. See, this 9 to 10, I'm not able to see anywhere in the report. But, I fed the report to ChatGPT and asked it to analyze, and it said it is 9 to 10. But I don't see that anywhere in the report. I don't know where it says in the report. So
I thought a PSMA scan was to find out if, in fact, any of the quote-unquote cancer has left the capsule. When it leaves the capsule, doesn't it light it up? PSMA will light up, and it will show that it's out of the capsule?
It will, but it also show up if it's in the capsule too. In other words, if it's an aggressive form of cancer, it'll show up even if it hasn't left the cancer. But most of the time, they've done PSMAs because there haven't been that many machines. They only do it when they're concerned about metastatic.
Sorry. There is a correction. I'm now reading the PSMA scan. I will read out. It says prostate appears enlarged, transverse diameter 5.4 centimeter, focal PSMA. Uptake is noted in a hypotense lesion, right posterior zone, size 1.3 centimeters by 1 centimeter. SUV max is 5. Primary score is 4.
Okay, that's different. That's a lot different than a 9 to 10.
I don't know how I got that 9 and 10 in the chat. Maybe there was an error.
Yeah, that you got to be careful with the AIs because they make errors all the time. Yeah, that's a lot different. 4 to 5 is a lot different. You may
Yeah.
be a candidate, but what I would do, and I don't know if you can get the sample sent to Decipher, if there's a way to do that. FedEx it to Decipher and see if they can do it or bring it with you when you come to the United States, if that's possible. But I would see a doctor at UCSF, either Carroll or Cooperberg, and I'll send you their information.
I don't
And
think Carol is seeing any new patients, Ray.
oh, Carroll is not? Okay, Cooperberg
Yeah.
is.
Yeah, and I
Yeah.
just posted his UCSF information in the
Oh,
chat.
Okay,
Cooperberg.
Lehman's got his hand up. Do you have something to add, Lehman?
Yeah, I was kind of curious, and I went because I had my PSMA done as well. And I do, at that point, they found one SUV max 7.4 in a part of my liver. I don't know if that makes sense. And then they did another MRI of the liver, and they said it was fine. So I don't know. I think, I assume that is what I assume I'm okay here, but I just wanted to let you know that's, I guess, sometimes appears in the PSMA report, and then they further check and tell you it's fine. Does
I
that
know there can
happen?
be there can be false negatives, especially I think in salivary glands.
Well, those aren't false. It's just that they will show up, because of the way the PET scan reads them normally. If you had something in the liver, you don't have any ascites or any kind of other hepatic diseases that you know of, right?
Well, so they did check it out with another MRI, and they told me it was fine.
Right. On the scans, the MRI and the PET scan, you can go to NIH at no cost. As long as you have access to your discs, you can upload them, and they'll even overlay them together and give you their opinion on both.
Okay, great.
Okay, real quick, Dean, you kind of joined us a little bit late. Do you need any time this evening, sir?
I would just like to pass on a few things. Yeah, just a few minutes if it works.
I'll put you down. We should be able to get to you.
Thank you.
Yeah, Pradeep, it's a little difficult because of your location, but that was excellent advice from Ray. The fact that you do get to spend some time here each year. If you could get opinions from our doctors that they've posted, that would be fabulous. Most probably a little bit more detail and involved, shipment of those things. I don't know if it's biohazardous. I don't know what it could be categorized as something because it's going internationally, but you'd have to do a little homework. You'd have to do a little bit of homework there to figure out how that works.
But based on the case that I presented, am I a good candidate for active surveillance?
Well, we've got some missing parts, but the third opinion, somebody said you had cribiform, and then another person said you didn't have it.
Yeah, two of them said no cribiform, and one of them said cribiform.
Well, cribiform, again, it can be small or big. If it's small, it's not as problematic as
no. It said in 10 to 20%, 3+4. It said cribiform found.
Okay.
Yeah.
Well, the one thing that will tell you whether you're in India or Indiana, you have time. There's time. You have time to make decisions and to try to find some more answers, because you've got three opinions now, and you're really kind of stuck. So I think what we're trying to say and we'll have some more input from the other gentleman. The fact that you do come to America for 2 months to visit your children, if you could make a move and make some arrangements for that particular trip, I think that if it was actually, if you had 3 + 3, 6 on one side, which I mean, on one side, the left side is completely benign. All three said there, but that's benign, correct?
Yeah.
Okay. All three said, okay, it's the right side, and of course,
The difference was only in red, in right mid, apex and base both were everyone was agreeing.
okay.
The main difference was in right mid.
Well, we do have some people here that do have 3 + 4 in various percentages.
Yeah.
You mentioned 10 and 20.
Yeah.
I don't know off the top of my head. I know we have some people with, 5 to 10%. I still think, I mean, Dan, what do you think? I think that until we get a little bit more concrete, he's right where he wants to be. There's no need to,
Yeah, I agree. I think go back to Gary's point that you have time, and it seems like you have a decent doc that is willing to stay engaged, but also put you on active surveillance, and he's not interested in treating you right away, which is a positive sign. Even with us, I mean, your +4 seems to be a relatively small percent. So you're in the around 10%, 10 to 20%. And it's in do you know how many of the cores had +4? Had the
it says right mid, that is 4 cores.
4 cores.
4
See,
cores.
out of 26, 4 cores are 4, 3 + 4.
And what percentage of those cores again was the grade group? I mean,
10 and 20.
Okay,
And
so
20.
it's relatively small percentage, and it's in one particular place. So I agree with Gary. You have some time. It's not like you have to get off active surveillance right away and seek treatment. You have a couple of years, and it seems like your doc well, I agree with your doc. You've got time. As long as you continue to do your PSA checks and you do MRIs and you do periodic biopsy, if things change and you want to track your PSA has come down. I mean, all of those are good things. So, I mean, I think you are a good candidate for active surveillance, at least for the time being. And the time being, from my perspective, is at least a couple of years.
You, as Dan mentioned, it's active surveillance. You have to be active. We tell everybody has a different PSA. Some guys up here get it every 3 months. I myself get it every 6 months. Some docs want it every 3, every 6. We've had a couple of people say once a year. We kind of strongly suggest that at least twice a year. Yearly MRIs, and of course. These lesions seem to be in one place. So now if you do get another biopsy, hopefully in America, transperineal rather than transrectal, they could use the MRI fusion guided biopsy and get into that particular area that seems to have the 3 + 4 and come up with a definitive opinion. But again, you've got time, and you've got, unlike all of us in the continental United States, you've got a little bit more of arrangements to be made. But like Dan says, your doctor sounds like you're on board.
If I can ask a question, quick
Sure.
question. Were these all adenocarcinoma?
Yeah, correct.
Okay. All right, good.
Yeah.
Okay. Does
Pradeep,
anybody else have anything for Pradeep before we move on? And Pradeep, do we have any other questions?
No, well, what would be the tipping point? My doctor seems to feel, he has suggested, he said PET scan is better than MRI, so he wants me to do a PET scan in October. PSMA PET scan.
Yeah, I think, I mean, if I were you, I would. Can you get the slides sent to New York?
Yeah,
Can we put Epstein and Zhao in the thing? Are you able to get your slides sent to New York? Because I would almost, because cribiform or non-cribiform, that's a big difference. That could possibly be a tipping point. And also, if you do have 10 to 20% grade 4, that could be also. I think if you can get the slides sent to New York, I would have Zhao or Epstein do a reading of them and find that out. And I would certainly make an appointment with UCSF to go see their doctors. If you need another biopsy, have transperineal. But I think the first step would be if you can get those slides sent to New York to do that. I can let me see if I can get
Eric put them in.
And Ray, I believe if there is cribiform, it will show on the PSMA PET scan.
Yes.
So that would also be something to confirm or not confirm that there is actually cribiform.
Now, see, Pradeep, it sounds like it's easy for you to get a PSMA scan. Here in America, that's kind of tough. Decipher, we could come by easy, and you can't get it. So, see, it's an international problem, I tell you. That's how it works. It's never the same. It's never the same.
PSMA PET scan is easy here too. PSMA PET scan is easy, very easy here too.
Yeah, PSMA PET is going to pick up more advanced cancer than. And if it's straight grade group 3, you're probably not going to get any value out of it. But if it's going to, like Andy said, if it's cribiform and if it's more advanced, you're going to get it. Pradeep, can you see the chat?
Yeah.
Okay. Do you know how to download the chat?
No, I'm not able to see the chat. I'm not. I can't see the chat.
Do we have your email?
Should be on the top right. Looks like a couple of pages, I guess.
Yeah, it looks like 2 notes.
It should have a number. It could have a number next to it of how many messages are in the chat. Do you have any red number on the top right of your screen?
Yeah, 7. Yeah, it's yeah. I can see the chat. Yes, correct. Yeah.
There you go. Okay. All right.
Yeah.
Does anybody else have anything for Pradeep? All right.
You
well,
can download the chat.
Wish you well with, yeah, make sure you download the chat.
So the 3 little buttons off to the right, 3 little dots. If you click on that, then you can download the chat message.
Got it.
So all that information.
Yeah, I got it. Yeah.
Okay. Good.
Okay. Yeah. Thanks a lot.
All
Thanks
right,
for all the suggestions. Yeah.
Well, make sure that you come back. I don't know what time it is in India, but we're
no, it's morning. It's morning here. It's 7 o'clock in the morning. Yeah.
7 o'clock in the morning. Do you like to get up early?
It's Singapore.
Yeah. Well, no. Well, from next week it will be worse because the clocks will be turned. So.
It'll be 6 o'clock in the morning.
Yeah, it will be 6 o'clock in the morning.
All right. Well,
that's
we want
okay.
to see a little bit of that Indian spirit. We want to see you back here next Wednesday.
Yeah.
Okay?
Yeah. Sure.
All right.
Definitely. Yeah. Thank you.
Okay. We definitely.
Gary, we also had BJ and Eric join.
Yeah, I saw Eric up on the top. Well, Eric, you need any time?
Nope.
All right. Good to see you. BJ, I saw him, and now we see the cafeteria or his back porch or meeting room or whatever that is. When he comes back on the screen, I'll say something. Oh, he didn't like my comment. He didn't like my comment about his room. All right.
I'll send him a message and see.
Yeah, all right. Okay, Brian's still sitting in his car as usual. Go ahead, Brian. What do you got?
Sitting in my car. Maybe I'm good. I'm just waiting for some doctors to call me back and get things scheduled. Andy, I did do what you said. You told me to because I'm still working on the biopsy thing, not the transrectal, but the other one. But I got to use my Medicare, so I'm talking to the Fred Hutch. Well, they're in connection with the UW down here in Seattle, the University of Seattle. So I'm talking with them. They actually put me on the schedule. I'm not on the schedule yet, but they put a referral in. So I've been doing that kind of phone work. And then Andy told me to reach out to my cardiologist, who gave me, I got a new heart valve like 2 years ago. So that could be a good reason not to get the
transrectal.
Yeah, the transrectal. So I typed out a nice thing there and sent that to my cardiologist. Now I haven't heard from him, and I haven't heard from my regular doctors. So I'm kind of waiting for everything. So, but I did request everything you guys talked about, the 3T machine, the 3 Tesla machine, just, all the stuff I've kind of learned here. So we'll see where it goes. And then we'll just see where that goes. But thank you, Andy, for that. So, and everybody else, I think I'll just wait.
I actually think that was Dr. Dan that brought up that if you had a heart valve, was Dr. Dan.
It wasn't
Dan
Andy.
Perchuk.
I thought it was Andy. Was that
No,
you,
it's
Andy?
Dan.
Dr. Dan said that was your ace in the hole because you can't take a chance with what you've had replaced.
Oh,
with,
yeah. Oh, no. Doc, he did. You're right. Dr. Dan did say that.
Yeah.
But I think Andy said something last week to kind of make me.
See if the cardiologist.
Regardless of who said what.
Exactly.
Regardless of who you're picking up, just like Hollywood Squares. See, like right now, Bill and Ken are in the middle in my square. But it doesn't matter who said it.
Exactly.
When they said it, as long as it was advantageous to you, it made sense. It was good advice. That's all that counts. So I'm glad.
Oh, yeah, it's good.
So you're kind of just plodding along. You're going to keep us informed what's going on.
Oh, I'll keep you informed. I always do. You guys are great.
Any questions? Any questions for the group?
Yeah,
Anybody got something for Brian?
I have one because I think the last time, to me,
Andy, hang on, Andy. It was directed towards Brian. And please raise your hand if you're going to ask a question, Andy.
Where is that?
On the bottom on the left.
I do have one more question. Oh. So I was in the meeting on Monday with Rick. What's it called? Active. The other meeting last Monday, and so I'm going to go to like the UW, which is right next to the Fred Hutch, to get my biopsy supposedly, and all that. But then I'm going to take those records and bring them to the VA hospital. Some people said that was a good idea. Some people said that, like Rick said, well, no, you should get your doctor and keep the same doctor, whoever takes the. I'm a little confused on that. Like, I'm just going to go get my biopsy and get all the information, and then bring it to another place, the VA hospital, rather than. Otherwise, I got to pay for it all out of Medicare. So I don't know if anybody knew anything about that.
Is that a Medicare question?
No. It's just I guess it's not really a question. I'll just I'm basically gonna go get my biopsy done at like Fred, the UW, and basically I don't need to talk to their doctors, but I'm gonna take that info and bring it to the VA. And I think Rick thought that might not be a good idea, so maybe I'll check with him.
Well, I don't see why you couldn't get your biopsy where you're planning to go.
Yeah.
And if you're getting is most of your primary care done by the VA?
Yes, all of it.
Well, then you need, I would think that you need to put them in the loop. I mean, that would just be my opinion, but it would certainly just take your information, bring it to the VA and see what they come up with, see what they say, see okay. where their opinion is.
Okay.
I think that would be the way to go. And Andy, you've got a question?
Well, I think last time Eric brought up a very interesting point, which is important. And of course, it's going to relate to money eventually. But if the VA is just not going to do a transperineal biopsy, we can then possibly assume that they have little to no experience doing transperineal biopsies. And I think that was the point Eric made.
Right.
So, if money, depends on how much money is involved, but maybe through Rick and through the groups here, you can find the place of excellence in your area that does transrectal biopsies. Work with your cardiologist to confirm that this is the only way you could get a biopsy. And if it's affordable to you, do that.
Well, I think I'm being cared for by the VA also. I think that given your unique circumstance with your heart, community care could come into play here. If they cannot do a transperineal in your VA facility that you go to, I'm pretty sure that you can get them to foot the bill and send you to somebody outside that does transperineal, because you can't risk a transrectal. But you need to work that out. You need to work that out between, the Fred Hutch, whatever that is, and the VA. So just kind of keep us posted, because that's a personal thing that you're going to have to work out. We really can't, we can't come up. We can tell you that transperineal is the way to go. Dr. Dan told you that in your particular case, it's the only way to go. You might have to push some buttons, talk to the patient advocate at the VA, but there are outlets for you to use to get the proper care. And of course, in the meantime, just keep all of us posted. All right.
Yeah, I've been doing all that for the last few weeks. All that talking. So I'm going to keep on it.
Well, just keep on, keeping on and keep us posted to what's going on. All right.
I will. Thank you. Yes.
Okay.
Thank you.
All right. Andy, you're up.
So I've been doing whatever research I can on performance of biparametric versus multiparametric MRI imaging for prostate cancer. And it seems like the latest that I was able to find was 2026 here. Yeah. And this was European Association of Urology. In doing a meta-analysis, they found that they were pretty equal in their diagnosis. I just wanted to see if anybody there had any input on this.
Well, I myself have a little input, because I either have read exactly what you read, or I saw a webinar stating I have a trouble with claustrophobia. I have to take goofy pills to get in the tube. Not really happy about it. And of course, I go once a year. So I am scheduled in March for a biparametric. I do not want contrast. The gadolinium issue came up.
Right.
And I understand it to agree with you. They seem to be, for prostate cancer, equal, that you don't need to contrast, which adds another 20 minutes at least. And 20 minutes to me in that tube is like a lifetime. So I'm going with biparametric. My doc at Mayo, they didn't give me a hard time. The last 3 have been with contrast, with and without. And I told them this time I want a biparametric. So I think the whatever's out there says they are equal. And of course, if they found something, and I had to go back and get one with contrast, I would say yes if I had to. But if I can get away for the shorter span of time and get the same results, that seems to be the word on the street. But I'm not really sure. Alan, what do you got?
I asked the same question of the head of imaging at Weill Cornell last fall. His answer was, for somebody who has not been treated, he did not believe that the gadolinium was necessary. He said sometimes, he said if they're not as professional at reading the MRI, it might help. He said, but if you're at a good MRI center, he didn't believe it was necessary. However, if you have been treated, he said the gadolinium was important.
Excellent. I'm glad to hear that, because that makes me feel better about my biparametric coming up. Thanks.
Yeah,
And he's considered to be one of the absolute experts in the field. Rick knows him. Rick's not here tonight.
He'll most probably pop in, or he's like sneaking behind the curtains.
Doesn't matter. I'm just saying, this, again, it's only one opinion, but he's considered to be one of the experts.
Well, we consider Epstein is only one guy, but we really value his opinion. So there you go.
I heard similar, especially since getting your, sorry.
You guys
I
take
just
a
posted
turn.
real quick some articles about gadolinium that are current, that we've shared in the past groups. Go ahead, Rick. Sorry.
No. What I was going to say is I was reading today that one person said for the first a with and without was good, but if after that you can get away with just without contrast, and most of the AI, which is really what you want, is using the without contrast anyway, is not looking at the contrast slides, and they're the ones that are comparing. So if you want to see if your lesion has grown from a year ago or whatever, the AI is probably better at it, because they're going to compare and they're going to be looking at the non-contrast MRIs to do that. So it's kind of backing up that same thing, you can probably get away without the contrast.
I actually just looked. I'm scheduled in July for my second, or my next. It's not my second, it's my third. But my second after diagnosis, and MSK has me down without contrast, which is what I thought.
Yeah.
Nice. Eric, real quick, did you come up with something about gadolinium? I'm sorry. Did you come up with something about gadolinium? Did you say there was something new out there?
Yeah, I have two. I just posted two current articles from fairly recent about the issue that we've shared in the past in the group.
Okay, excellent. Okay.
Especially the Medscape article that
I have a sub part to all this because it relates to the diagnostic part. That relates to micro-ultrasound. Now, you're all familiar with Dr. Klotz in Toronto?
Yeah.
Yeah, I mean, he's kind of the man with that. There have been recent papers in tomography that have come out with that in the detection of clinically significant prostate cancer. And in the reviews, once again, they're saying that they're not really seeing a big difference between that and the MRI. Now, with the case with all of these readings, again, we come back to what everyone says is you need a person in place of excellence to be reading all these things to know that it's being read correctly. It's not just a generalist kind of reading. So those were the two things that I was looking at. Klotz has done a lot of talks on the micro-ultrasound, and even using it with focal targeting biopsies. So,
well, micro-ultrasound, of course, is something new on the block, which is a
right.
wonderful thing, because it can be done in an office. It's a small machine. It can be done in an office. Here again, hard to come by. At one time, there was only one in the state of Florida that had a micro-ultrasound that you could go to. I believe it was UF, and I believe that's gone now. So I don't even know. You can get, I think Exact View is the person that makes the micro-ultrasound.
Yeah.
So you can get on their website and try to find out if you could get one. And of course, they say it's very comparable to the image of a 3T Tesla, a 3T Tesla MRI. So again, the thing about prostate cancer and the ever evolving things that we find out, that's an excellent machine. But like I say, here, it's pretty hard to come by. I don't think the Mayo has one. I asked about it when I was there, and he said that they didn't have one when I spoke to him last year. So, and I guess, it's MRIs are big money makers, big machines. They take a lot of people to operate, a lot of different gases and whatever. Micro ultrasound, you take around on a little stand. So you could have people being a little bit not wanting it because there's not enough money in it. I hate to say it, but medicine is about money. So I'm not going to sit here and bullshit people.
We've already spent a lot of money on the MRI machines. It's kind of
they're
like
multi-million-dollar machines, so they got to get their money back. And these other things, I'm sure you don't buy a micro ultrasound for $250.
No,
but I'm sure it's not $1 million.
No.
So it's going to take time, and it's going to be wonderful for the people that cannot get in a tube, period. And it's going to be there to work in conjunction. Again, everything in medicine, you've got like the left working with the right, and when they come together, it's normally good. And I think that we've had this discussion before with the, when ultrasound came on board. We've had a webinar about it, I believe.
I did. Hey guys,
it's not going to replace. It's going to work in conjunction.
Hey Gary, I did post the article we've been talking about where micro ultrasound is non-inferior to MRI.
Right.
But what we talked about in the past is that since the micro ultrasound is usually done in the office, it's only as good as the operator. Since you don't have a separate radiologist looking at the images, it's done in real time. So finding a good person or doctor that's had many, I'll say, scans or years of experience is probably the most difficult part. So I would reach out to the company I put it in the link there in the chat and see who has the most experience in your area.
Now on the biparametric, do you know if that's a 1.5 or a 3?
It's a 3.
Usually it's 3.
Yeah, it's a 3 also. Okay.
It just means there's no contrast. They don't change the Tesla strength.
Right.
And as Andy and Eric said, it's only as good as the people doing it. So as time evolves with this wonderful piece of equipment, people will become more acquainted with it, better with it, and will know even better where you can get it. And there's people that can't go in an MRI tube that are really at a disadvantage for other medical reasons. And now this new piece of equipment is going to it's not on the horizon. It's in use, been in use almost probably, would you say 2 years, Eric? Something like that. It's been around.
Yeah,
yeah. And of course, you got somebody like Klotz that's pushing it. And, he's like the father of AS. So, again, that's something good. Is there anything else you need, Andy?
No, I did write to Dr. Klotz. I haven't heard back.
You want to take a trip to Canada?
Sure.
Oh, there you go. That might work.
Yeah, I'll do it in the summer.
Yeah, go in the
summertime. Not winter. Anybody else got anything for Andy?
Anything else for Andy? Levin?
Yep.
Yeah, I don't know if it's mine, but I have a related MRI question. So if it's
you're up next, Levin. So go right ahead.
Okay, great. So and I have to say, so I'm very much kind of at the basic part of this. I'm going to have an MRI in September. It's in Antwerp, the University Hospital there. I think they are. I don't think they are 3 Teslas. I think they are maybe 1.5. I have to check. But so my question is, what should I ask for at a minimum to have a decent comparison with the previous one? And the previous one was also there. So I looked at my last report, and it just has, for one Pirates 4 region, it just describes it's an oval zone with a particular length. That's kind of all the most detailed, specific measurements I've seen in the last report. So I feel like it's not really up to standard. But so I'm kind of wondering, what should I push for in the kind of the comparison of the MRIs.
Comparison wise, you would want to know the size difference, I would think, from the previous one.
But
And
the size of
sorry?
the size of what? Of the prostate itself, or just the Pyrex region, all the Pyrex regions, you know?
Definitely the size of the lesions and the quantity of the lesions are two big things. And of course, I think the size of your prostate would be helpful as well. But again, you have to remember these MRI scans are being read by a radiologist, may or may not be the same one as the previous one. And they're looking at a screen and they're trying to do the best, you know, guess of measuring, and they're all going to be somewhat different just because there's humans involved and, you know, some, you know, expertise involved, but nothing's definitive in terms of sizing or grading. It's all opinion based.
But you can also get a second opinion leaving on your MRI once your MRI is done. So that's
I did put Dr. Baris's information in the chat from the NIH. I did it at 8:24 p.m. So it's be higher up there, but all his information's there, and he's been in contact with me regularly. So as long as you can make sure you have those images, they can send you to where you can upload them, and in a matter of days, they'll get you your information.
Yeah, it's the same office as Dr. Choki.
They're together, yes.
Yes, good. Thank you very much for that.
Although Levin is in Singapore, so that
shouldn't matter.
Should be free still.
Okay.
Although hopefully it's not because of his location.
Excellent. Okay. Well, you can certainly, that's an avenue to explore.
Is that information in the link as well in terms of where I can get a second opinion based on the images?
Yes.
Yeah. I can repost it for you for everyone to see. Hang on, let me find it. I'll get it in there.
While Eric is doing his, he's really great at what he does, especially posting all these, all the information. Make sure that you gentlemen download it before we say goodnight, because then it's gone. So you can just take the chat. I work from an iPad, an iPad, so I can't do that. But I guess anybody with a desktop, what's it called, Ray? You take it and put it where? Download it to something, I guess.
Yeah, you can just download it, or you could with an iPad or an iPhone, you could screenshot it too.
Yeah, I do that. I screenshot it, but everybody else. Yeah. But it's important to make that move before we say goodnight. Otherwise, that information, although you can contact one of us and we can get it. But
I try to remind everybody before we close out. Now's a good time to download the chat.
Yeah, we'll try. You know, and I'll give a shout out. Tonight is going quite nicely, so it just came to my head. So I just wanted to make sure. Yeah, just to make a comparison, Levin, of, you know, before and after. I mean, that's what you're going to be looking for. To have somebody find any distinct differences in, you know, in the images. Your prostate gland most probably may have grown a little bit, hopefully not too much, between the last one and the new one. Density, you know, they'll give you that's given to you at that time. That's what you want to ask, but I mean, I think it goes without saying, because you know they're going, you know, they're going to look at both images and hopefully they're going to tell you, you know, everything's good. Anybody else? Anything else we can do for you, Levin?
No, thanks. That's great. Thank you very much.
Levin, can you find a 3 Tesla machine at all near you, or do some homework?
So now that I know that 3 is better than 1.5.
Yeah, if you can, that would be ideal. But
and you say you go to
is better than no MRI.
You go to Brussels. Is that where you get the MRI?
It's Antwerp University Hospital. Yeah.
Okay, all right.
I will ask. I don't know for sure what they have. Yeah. Thank you.
Well, there might be a good possible. I mean, if they
might
don't
have 3
one,
teams. You might have a 3-T machine there.
if they don't have one, they'll certainly should be able to tell you the nearest proximity to a 3T machine and see if you can make that work. That would be, and it would be ideal. I mean, if you had a 1.5 on the previous one, if you could definitely get a 3 point, if you get a 3.0 this time, that would really be good, because they'll have much more definition and they'll be able to tell you really what, in better detail, what they see and what's going on.
According to the Antwerp University Hospital site, they have both 3T and 1.5. So
this is just like an international caucus. You know that we got people from India, we got people from Singapore, we got people finding out about stuff at that, tens of thousands of miles away. Who's better than us? That's all I'm saying.
So how do you score it on the Olympic scale? How do you score it on the Olympic scale?
Oh, this is a 10, man. You're looking at right here. You've got a 10 every Wednesday right here on the screen. But Dan,
are there
any anything for leaving?
Yeah, leaving. Are there any local support groups that have gone through this maybe already that could help out in Singapore?
So yeah, no, the only support group I've found is this one so far.
Okay.
Well, you don't have to look anymore. You don't have to look anymore. You're done looking. You found where you want to be. It don't get better than this. Like we said before, this is priceless. This is it. You can't put a price tag on this. Just listen to us tonight. It can't be done. All right. Anybody else got anything before leaving leaves?
Anything else?
Anything else? Going once, going twice? All right. So, Barrett Jackson. Dean in Denver. Yep, turn around. Turn your mic on. You're in the spotlight now, buddy.
Okay. Hopefully I won't disappoint. So yeah, just a couple of things. I know it doesn't look like Hugh's here tonight, but he passed on a local guy in Denver, Mike Wynn, I believe his name is.
Oh, yeah.
Anyway,
yes,
I was able to,
Mike Wynn. Yeah, we know Mike Wynn well. Go ahead.
Yeah, anyway, I was able to connect with him, and he gave me the name of a guy that does transperineal biopsies. And so I'm going to get in there. Actually, I see his assistant on Friday, and then hopefully I can get it scheduled without having to see him first.
Nice.
But anyway, he's at UC Health, and it's one of those centers of excellence. So that turned out really well. So thank you. Next thing, just to pass on some information. So last time, I think it was Eric downloaded, and I think it's in the chat again, a number of places to get second opinions on MRIs. I was able to get my discs and send it to Peter Chokwe and Baris, I guess his name is.
Very good.
They turned it around in 3 days. And so it was good news. There really wasn't any change from what was read or how it was reported from the time before. So that was comforting. One other thing is I attempted to send it to Johns Hopkins, and I talked to, I don't recall who I talked to at Johns Hopkins, but they say they no longer do outside second opinions.
Oh.
Unless you're at with a doctor with Johns Hopkins, you won't. Yeah, it's not possible. And he kind of alluded to a legal
state law, California state law thing.
Yeah. So anyway, just so everybody knows that, and not saying don't try, because maybe I just happened to get the wrong guy at the wrong time, but that was the feedback from him. And just one more thing, or two more things. I happened to listen to ASPI, a recording of a meeting with 3 urologists, and I apologize, I didn't get all their names other than one, Dr. Wu, and they presented 3 trials of transperineal versus transrectal, and the 3 trials were Probe, PC, Prevent, and Translate. And one of the doctors was from England, the UK, and the takeaway that I got is they aren't as opposed to transrectals as maybe initially thought. I don't have a lot of data to present to kind of back that up, but that was generally a consensus of all of them. Not that there's still not risks, but it was kind of interesting to listen to that. But I don't know if you guys look at ASPI at all.
Yeah.
Anyway, it was one of the meetings here not long ago. And then with that, what came about, or what also was discussed, is why don't facilities that do transrectals, why aren't they doing I think they called it like an iodine flush. It's probably not the right term, but to go ahead and just like we do for our skin when we're going to, be operated on or whatever, they clean it up with iodine. Well, apparently there's a technique where they could do that in your rectum, and they just question maybe that could be a part of the transrectal procedure going forward. And I apologize. I wish I would have got all the doctors' names.
I guess if it was better, they would all do it, but maybe it's just not enough efficacy to warrant even the process. Like,
quite possible, or I think like Gary said, it all comes down to money. So
that too,
yeah.
But yeah, that's interesting, but obviously they don't do it.
No, they just brought it up. And then the last thing is, as I said, I'm getting ready to schedule a transperineal. My question is, and I can research it myself, but does anybody have kind of the preferred methodology? I guess there's several ways to do a transperineal. Am I mistaken, or?
I don't know.
There's anesthetics they can give you. Some people are knocked out. Some people just, I think, get like a Valium or something in a local. I think that's different, but I don't know if there's really difference in the procedure itself.
There's different methods in the actual procedure itself. I, through AnCan, was able to get a precision point transperineal biopsy. It's called using the precision point system. It's I didn't see it, didn't know anything about it because I was sleeping, we're having a nap, but it enabled them only to poke one time and then access different parts of the gland to get the the specimens. So as some people stay awake, kind of like in a chair, like in an OB/GYN that the women go through, legs up, that kind of thing, and have said that, and actually watch on a screen. I prefer to be knocked out and don't want to know what's going on. That's the way I go. So there are different ways to do it. And I believe they do have a system that's even newer than Precision Point. I don't know the name of it. You'd have to do a little research, and something I should look up myself. I saw it once and I didn't note it, but so there are different ways that they can do a precision, they can do a transperineal, but the object is they're not going through the rectum, through any contaminated area. You don't need the antibiotics, and the chance of sepsis is 0. So, yeah. And I think the reason in America why transrect is still done in lots of places, a money thing. It's a small procedure that can be done in the doctor's office, and not having the facilities, the operating rooms and staff to do that. But you know how we feel about transperineals. And I'd just like to note to the other members in the group, you can see Dean getting directed to one of our guys, Mike Wynn, turning him on to somewhere where he could get a transperineal, inquire, ask questions. That's what the group is all about. It's a support group, and that's what we do. If we don't have the answers, we try to find the answers, and we have enough of peers that you can get some really good info and support. Go ahead, Andy.
So correct me if I'm wrong, but I always thought the primary purpose in the transperineal versus the transrectal was that you could access the anterior prostate better and therefore get a wider range of biopsies. Is that correct?
That's like an added option that comes with the program.
Yeah,
I think
that's true, but
yeah, I think the reason they did it was it's got to be the sepsis, it's got to be the antibiotics, people that are allergic to antibiotics, and the fact you're going through something very unsterile into something sterile.
Right.
But you were correct. As part of the deal, an added option with that particular procedure, they found out that they were able to get to places that they couldn't with a transrectal.
Well, I'm just bringing it up because
I don't think that was the primary cause. I think that was something they found when they started doing it, is that they could get to places they couldn't get to before.
I only bring it up because Dean said these three urologists from different areas, were trying to point out that there's less difference and it's not as bad as we thought. But I'm thinking, so what? If I can get biopsies better in areas that the transrectals won't, I don't care about the other reasons.
Well, yeah, that's a personal thing too. And like I always say, if we had a statistic for the sepsis part of that equation, it's very minute. I mean,
right.
And I say to all of you, do you want to be that guy?
Yeah,
do you
right.
want to be that one guy in 10,000, or do you want to be that one guy in 50,000? I don't want to be that one guy in 100,000.
Ever.
That has to.
I think it's more than that. I think it's more. I think it's like 1% or something.
It's way out there. It's way out there. But you don't want to be that guy. You don't have to be that guy. You don't want to be that guy. And that, that's my, that's my take on it. But I don't, I think it was all about the bacterial, the sepsis, and the antibiotics was the main cause. And then they found out by doing it, when they did it, I don't know who did the first one or how it all came about, they realized that they could get to areas better than previously done in transrectals.
Anything else for us, team?
No, I was just going to say, I don't mean to do anything other than just kind of give feedback on what I heard from this ASPI talk. And maybe one more thought that they had, is there more urinary retention with transperineal versus transrectal? Does anybody know about that?
You mean from a healing standpoint?
I didn't get the whole thing. It just said people can have urinary retention issues from one method to the other.
I've never heard that. Maybe blood in your urine, semen might be a little messed up, but I don't think urinary retention, I think BPH, and that's got nothing to do with a transrectal or transperineal biopsy. So I don't, I'm at a loss about urinary retention. It was never brought to my attention before I did it that, something, there would be any kind of urinary retention, probability of urinary retention.
And just,
it says not any higher.
I would think the number of pores would play a role more than anything.
No.
Yeah.
We're all the same in type, but we're different in kind. So whatever gets put in the books about what should be, like you should take a medication for this or do a special exercise for that, it doesn't mean it works for everybody the same. So I think it'd be hard to determine, really. I don't know that they're bothering to study that many people to make the determination. I would think in both cases it's possible.
Yeah.
Absolutely.
Yeah, and just to be clear, that came from I get involved in this Mayo chat group on prostate cancer, and that comment came from that chat group. So I wanted to throw it.
That could be one person that has an issue,
Right.
you know, and of course,
Agreed.
and it gets kind of blown up, gets kind of blown up. But that, of course, that would be a valid question. If when you get this organized, when you get your transparent heel organized, you could mention it to the doc. You know, is there any kind of urinary retention issue? See what they say and come back to us. You know, let us know.
For
Is
sure.
there anything else, Dean?
Yeah, I just wanted to thank everybody for, I've only been here, whatever it is, 3 times. And gosh, the connection through Hughes to Mike Wynn and then getting me on to a better, I think a better path.
And yeah, we're going to hang out with a guy from Singapore, from India, from Canada. Come on, man.
Yeah.
This is the place.
I just appreciate it. Thank you.
Urinary retention is a potential issue with any biopsy. Anytime you start poking a prostate, you could have urinary retention, but it's a low percentage. And then 2, the ASPI video that you were talking about is posted in the chat.
Oh, thanks, Dan.
Now there's also a webinar this Saturday at noon, correct, Dan? We should try to plug that.
I don't recall.
Yeah.
February 28th.
Yeah, you got it, Eric? It's a webinar.
I think it's either this Saturday or next Saturday. Let me double check.
It's this Saturday at noontime. What is it? MRI. I'm scheduled to. I don't have my phone. I'm scheduled to attend. Yeah.
Saturday, February 28th at 12 p.m. Eastern.
That's the one.
And what's the title?
Prostate biopsy: the beginning of the end? Question mark. With Dr. Mark.
Yeah, that was in Howard's.
It could be the beginning of the end. What?
That was in Howard's active surveiller as well.
Yeah. So, and what I do for Howard, I hope you guys sponsor Howard and contribute to his surveiller, because he's just the best, and he devotes a lot of time and does a lot of research, and he's just a wealth of information. Yeah. When you sign up for a webinar, it says, "How did you hear about it?" Regardless, I always put the active surveiller. I always give Howard the credit. It's ask you if you get it from ASPI or this one or that one. Howard's one of us, so I definitely hit it to Howard. And I guess maybe I shouldn't say it with all this being recorded, but I could care less. So I'm gonna say it. I'm gonna say it anyway. So I always say that I found out.
Maybe it's better than the end of the beginning.
Yeah, we'll have to find out. Well, I plan to watch on that. And of course, they're always recorded. So if you have a previous engagement and you miss it, you can always go back and watch the recording, which is great.
That's great.
And, all right. I tell you what, maybe for once we're going to wrap it up a little early on a Wednesday night. That sound good to everybody?
Yeah.
Does anybody have anything in the group?
BJ didn't come back. I did see him after I made the comment about the room, but
he said he'll talk next week.
Oh, okay. All right. That's cool.
Don't forget to download the chat.
Yes. Thank you, Dan.
Thank you.
Download the chat now.
Okay.
Or at least click on all the links.
Again, welcome.
Yes.
Welcome our new friend in India. Make sure you come
Thank
back
you.
tomorrow. I guess 6 o'clock next. 6 o'clock.
Yeah, so thanks for all the advice.
You're welcome.
Appreciate it.
Let us know how it all works out. You guys,
Sure.
moderators,
Good
hanging
evening.
out for a minute.
Hang on, moderators. Everyone else, have a good night.
Everybody else, have a good night. Have a safe
Right.
evening.
Thank you.
Hi, guys. Thank you so much.
Good night, everybody. You can cancel the recording.
I got it.